So basically, sure, my aim of doing thoracic anatomy, I don't want to do it like an anatomy lecture. I actually want to do it like a surgical anatomy lecture. Okay.
Yeah.
So rather than doing it as a single session of discussing all the anatomy, I think it's better that we do it with a relation to surgery. So the first one that I'm going to do is the chest wall anatomy. And particularly, I want to talk about all the incisions that you can do on the chest wall. And I want you to understand, how we correlate the chest wall anatomy with the incisions which allow you access into the chest. Okay.
Yeah.
So I think you'll probably have to do this as 2 or 3 sessions rather than a single session of anatomy, because otherwise it gets boring. This is not anatomy. You guys are surgical trainees and you need to know how to apply the anatomy in your surgical practice.
Fair enough.
So how many people are there online? I can't see now because I'm projecting from my screen.
So. Let me just check in a sec. We've got 11 people with us so far.
Okay. And what is the level of training of the people?
So I can see we have Mr. Kadri from Blackpool, and then I can see some other medical students as well. And then there are some people from Thoracic Gurus. I'm not sure what level they are, but I welcome you all.
Can they speak, or are they muted out?
Can speak. No, they can speak.
So before we start, just give me a feedback on what is the level of the audience participation, and then accordingly I'll try to tailor it. Can somebody? How many of you are FRCS exam going, cardiothoracic exam going students? I know Kadri is. Who else is? Are there more FRCS cardiothoracic surgery? Okay. How many are general surgery people, approximately? Is it predominantly general surgery?
I can see most of the medical students so far.
Medical students, okay. Even better.
Can someone from attendees please tell their level, please?
It's important for me to know what is the level of the attendees so that I can direct it at the appropriate level. Yeah, who's that?
Hello, good evening, sir. Dr. Shubham Gupta from Kolkata, R.N. Tagore Hospital. Sir, I'm pursuing DNB cardiac thoracic surgery, currently in the 3rd year.
Well done. Very good. Okay, that's good. So 2 people at a very senior level, which is good. I know Syed Kadri is there and you're there. Okay. And then medical students, and Shua is at general surgery level. Okay. So let's get cracking. My aim today, or actually over the next few lectures that we will do, I don't want to do the whole anatomy in a single session. That would have been very easy and I could have just gone bang, bang, bang. But what I want to show you is how you correlate the anatomy with the surgical practice. Okay. All right.
Yeah.
So basically, it's important for you to know the muscles of the chest wall before we proceed with any surgical intervention. And the chest wall is actually very easy because anteriorly there's one big muscle, which is the pectoralis major. Yeah. Everything below your nipple, that big fat muscle is pectoralis major. And if you take out the pectoralis major, as you can see here, on the right side, there is the pectoralis major, and on the left side, we've taken away the pectoralis major. And so there you have only really 2 muscles that you have to look for, which is pectoralis minor and the serratus anterior, which comes laterally. The subclavius is present, but that's more important in thoracic outlet, which we will discuss in another lecture altogether. So really, anterior thoracotomy, if you talk about anterior thoracotomy, besides the skin and the fat, the one muscle that you cut is actually the pectoralis major. Okay. And then if you are lateral, then you might cut some fibers of pectoralis minor. Okay. So that's the correlation that you have to understand. Now, most of us operate from the back. All of thoracic surgery, open thoracic surgery is predominantly done from the back. And from the back, there is only one muscle that you have to remember, and that is latissimus dorsi. Okay. So latissimus dorsi, which actually comes along with the thoracolumbar fascia. So if you are ever asked in an exam, what are the muscles that are in the back? One is latissimus dorsi, and the second one is serratus anterior, which comes laterally. If you come to the medial border of the scapula, then you get this trapezius. Somebody's kid's voice is coming, so just switch off your microphone. Switch off your microphones, please. Yeah. So really, I have said only 4 names so far. 2 in the front. One is pectoralis major, one is pectoralis minor. One at the back, which is latissimus dorsi, and one on the lateral aspect, which is the serratus anterior. Okay, is this clear? So this is serratus anterior, this is latissimus dorsi. Serratus anterior and latissimus. Remember those 2 names. And if you come to the front, it is pectoralis major and pectoralis minor. So when you're doing a posterolateral thoracotomy, you actually cut the latissimus dorsi. Okay, you cut mainly the latissimus dorsi, and you try to preserve the serratus anterior. Okay, can you see this? Serratus anterior is laterally. Is it making sense? One of you has to keep the full microphone on so that you can give me a feedback. Yeah.
Yeah, it is indeed.
All right. Okay, so pectoralis major, pectoralis minor in the front. At the back is latissimus dorsi and serratus anterior. And once you've got through these 2 muscles, once you've got through this layer, then the next layer in front of you will be a thoracodorsal fascia. And once you open the thoracodorsal fascia, then you see the ribs. So the ribs lie below the thoracodorsal fascia. And in the intercostal space between the ribs, there are actually 3 muscles: external intercostal, internal intercostal, and transversus thoracis. Okay. But when you cut and do a thoracotomy, you just cut them en masse. You don't individually cut each muscle separately. You just cut them en masse, and I'll show you in a minute. So the reason why you need to know the surgical anatomy of the chest wall is because you want to make an incision to be able to get into the chest and operate on the organs within the chest. Whenever you make a surgical incision, the philosophy that you follow is number 1, which is the most important thing, that you must have a successful surgical outcome. So if people talk about laparoscopy, or they talk about minimally invasive thoracic surgery, and they try to preserve the muscle, however, they do not do a complete cancer operation within the chest, then it is complete loss. In that situation, I'd rather that you convert the minimally invasive into an open thoracotomy, but please make sure that you do a correct cancer operation for the patient. Do not compromise the operation for the access. I hope that makes sense to you. When you make a surgical incision, you want good exposure. You want good exposure to the front of the lungs. You want good exposure to the back of the lungs. You want good exposure to the top of the hilum, and you want good exposure to the bottom of the hilum. Okay, that's very important. In addition to that, you want to cut the muscles and suture them back in such a way that you preserve the chest wall function. You don't want to lose the chest wall function because it adds value to the postoperative recovery of the patient. Incisions on the skin should ideally be along Langer lines so that the healing of the scar tissue is minimum and it is cosmetically acceptable to the patient. So it has got to be cosmetic, and that is why the minimally invasive thoracic surgery is coming to picture, which is video-assisted thoracoscopic surgery. But I'm not going to talk about that at the moment. I'm going to focus more on open thoracic surgery. And whenever you close, the closure must be along the cuts that you've made. So don't cut a latissimus dorsi and suture it to the serratus anterior. That's not a good idea. You have to make sure that the 2 ends of the latissimus dorsi come together appropriately. The problem is when you do a posterolateral thoracotomy and you cut through the latissimus dorsi, you'll be surprised that the muscle retracts completely. It really does. And when you look down to close, all you will see is the fascia and the fat. And if you don't go digging underneath to pull the muscle back, the chances are you will suture just the fascia and the fat and forget about the muscle. And that will affect the chest wall function. Okay. So what are the incisions that you will see in thoracic surgery with respect to the anatomy of the chest wall? So the commonest incision on a chest wall is posterolateral thoracotomy, something that comes from the back and comes to the lateral side. Okay, so posterolateral. Most thoracic surgery can be easily done with posterolateral thoracotomy, and I'll show you in more detail what I mean by that. The other common incision is anterolateral thoracotomy, which means you come from the front and extend it laterally to get good access. For you to do a posterolateral thoracotomy, the patient has to be in the lateral position. So if you're operating on the right side, the right side should be up, the left side should be down, and the lung has to be isolated. So you do what is called as a single lung ventilation, which means the double lumen tube is on the left side, and you selectively collapse the right lung, and thereby you can enter into the right chest. The third operation which you will hear, or an incision on the chest wall which you will hear, is Chamberlain's procedure. Chamberlain's procedure is an incision that you make in the second intercostal space, either right or left side. Okay, and this is usually done when you're trying to get to the paratracheal lymph nodes or a mass in the anterior mediastinum. For this, the patient is lying supine. So the patient is supine, you make an incision in the second intercostal space. And as I told you, there are only two muscles in the front. One is pectoralis major and the second one is pectoralis minor. And you cut the pectoralis major and minor, you get in between the intercostal space and get into the chest. Okay, and I'll show you pictures of all of this, so don't worry. The third incision is anterior thoracotomy, and this is commonly used in trauma. Okay, when you have somebody who has collapsed, crashed in the A&E, and you've got a chest full of blood, or you've got an acute arrest, the best incision is an anterior thoracotomy, where the patient is on the back and you make a slash right across below the nipple line and get into the chest. And in that situation, you only cut pectoralis major. Usually minor doesn't come that low, and you get into the chest by cutting the external, internal, and transversus intercostal muscles. There is a concept called as muscle sparing thoracotomy, which means you don't cut any muscles, you just retract the muscles and you get between the space. And I'll show you pictures for all of these. And the last but not the least is something called as axillary thoracotomy, which means a vertical incision. So the first first 4 or 5 that I've told you are all horizontal incisions, whereas axillary thoracotomy is a vertical incision which is done in the mid-axillary line. Okay, you make a vertical incision in the mid-axillary line and then you go about it. The one other operation which is very, very commonly done in thoracic and cardiac surgery is a median sternotomy, which means a cut across the midline. The beauty of this incision is that you do not encounter any muscles on the chest wall. And as soon as you cut skin and fat, the next structure that you reach is the periosteum of the sternum. So it's very, very easy and quick to get into the chest. There is something called as clamshell, which is 2 anterior thoracotomies, one on the right side, one on the left side, both joined in the middle by cutting the sternum horizontally. In a median sternotomy, it's a vertical incision. In a clamshell, it's a horizontal cut. Obviously, when you do a clamshell, you are at a risk of cutting the internal mammary artery on the right and the left side. Okay, so you do compromise the blood supply, but this is a very good operation when you're doing very good incision, when you're doing large tumors, or when you're doing an emergency cardiac arrest, or somebody with a cardiac stab wound to the heart. You make an anterior thoracotomy right, left, and just join the two in the middle, and you're straight away onto the heart. You can open the pericardium and get control of the bleeding from the surface of the heart. And a hemiclamshell is when you cut in the midline and go laterally, either right or left. And I'll show you images for all of these, okay? So this is this is a posterolateral thoracotomy. This is an anterolateral thoracotomy, or an anterior thoracotomy if it's more to the midline. This is a median sternotomy. This is a Chamberlain's incision in the second intercostal space. And this is an axillary thoracotomy. Is it making sense? Median sternotomy, Chamberlain's incision, anterior or anterolateral thoracotomy, axillary thoracotomy, and this is a posterolateral thoracotomy. Is it making sense, guys? Yes or no?
It is. Yeah.
Yes, sir.
So this is a common question that you're asked in the exam. Please describe a posterolateral thoracotomy. Even in the FRCS general surgery exam and in the FRCS cardiothoracic surgery exam, you're commonly asked, describe how will you enter the chest by doing a posterolateral thoracotomy. And that's why the anatomy of the chest wall is quite important. So this is, you got to look here. The important thing when you're entering into a chest wall is you want to enter where the fissure of the lung lies. Because when you separate the fissure of the lung between the two lobes, you will actually encounter the pulmonary artery deep in the fissure. Okay? And the correct position for the fissure is in the 5th intercostal space above the 6th rib. So whenever you make your posterolateral thoracotomy, before making an incision on the ribs, you actually put your hand below the scapula and go all the way to the top and start counting. Usually you will feel the second intercostal, second rib. You cannot feel the first rib, but if you retract really well, you may be able to feel the first rib. But you count your way down to 1, 2, 3, 4, 5, and 6. And as you can see, if you make an incision on the 6th rib and peel off the periosteum and get into the pleura, you will actually come to the horizontal fissure. On the right side, you will come to where the horizontal and the oblique fissure meet. So that is the real key for surgical intervention. And posterolateral thoracotomy ideally should be placed in the 5th intercostal space above the 6th rib. Okay? So this is how you measure. How do you decide? Because once the patient is lateral, you cannot see anything of the chest wall. Once you're painted and draped, you can only see the chest wall like this. So the only point that is constant on the lateral chest wall is the tip of the scapula. This is the most important landmark for identifying which space you go to. And usually, if you make a point at the tip of the scapula, that usually corresponds to the 5th intercostal space above the 6th rib. So what we do is we feel for this vertebral, this thoracic prominence of the vertebra. We feel for the medial border of the scapula. We make a point here. We make a point at the apex of the scapula, and we make a point at the lateral or the posterior axillary line. And we join A to B to C. And when you get into this space, you will actually enter the 5th intercostal space above the 6th rib. Okay? So always, whenever in exam you're talking about a posterolateral thoracotomy, you've got to start with, I will take informed consent. The patient will have single lung ventilation. Beside that you're operating, you will drop the lung down. The patient is painted and draped. You cut the skin and the subcutaneous tissue along the incision line that I showed you. You cut the latissimus dorsi. Do you remember that picture I showed you? Latissimus dorsi, yeah? Yes. Then you do not cut the serratus anterior. As far as possible, you try to preserve the serratus anterior, because the serratus anterior is important for functioning of the scapula and the shoulder joint, okay? And if you cut the serratus anterior and cut the nerve supplying the serratus anterior, then you will get a condition called as winging of the scapula, okay? Which means that the scapula, your shoulder will move up and the scapula will move away. And that is not a good outcome for the patient. Remember, the serratus anterior is supplied by a nerve, which is nerve to the serratus anterior, also called as thoracodorsal nerve. It comes from the axilla to the serratus anterior at the top. So if you ever have to cut the serratus anterior for whatever reason, say you're doing a posterolateral thoracotomy and suddenly the patient is started to bleed and you need to get control of the bleeding or do an internal cardiac massage, you can extend your posterolateral thoracotomy anteriorly But always make sure you cut the serratus anterior at the lower end, not the upper end, because the nerve comes from the top, not from the bottom. So if you cut the serratus anterior at the lower end, then you will save the functioning of the serratus anterior. But ideally, you try to avoid cutting the serratus anterior. Okay. Then I told you the next area is called as thoracodorsal fascia. You cut the thoracodorsal fascia, and then you lift up the scapula, use a scapular retractor, put your hand beneath the scapula on the under surface of the scapula and start feeling for the ribs from number 1, 2, 3, 4, 5, and 6. And when you feel number 6, you make an incision on 6th rib, which will correspond with the 5th intercostal space. When you made your incision on the 6th rib, you elevate the periosteum of the 6th rib and you open the intercostal muscle, and then you apply a retractor to the chest wall. So let me show you the operation, how we're doing it. So this is the tip of the scapula. Always the tip of the scapula, 1 centimeter below, make 1 point. Medial border of the scapula, spine of the vertebral column, make 1 point. And the posterior axillary line, join this. This is the right side up, okay? So the surgeon is standing here, which is the back of the patient. The assistant is standing here, which is the front of the patient. Once you've drawn this line, then you cut the skin and the subcutaneous tissue in line of that incision. Again, look at the tip of the scapula. Yeah, can you see that? Once you've done that, you're cutting the fat to reach the muscle. Once you've cut the fat to reach the muscle, then you cut the latissimus dorsi. Can you see the cut end of the latissimus dorsi? So you cut the cut end of the latissimus dorsi. The serratus anterior lies anteriorly because you're standing at the back of the patient. So you save the serratus anterior. You cut the thoracodorsal fascia. Put your hand inside here deep to feel the ribs. Count the ribs, 1, 2, 3, 4, 5, 6. When you come on the 6th rib, you take the diathermy and make an incision on the surface of the 6th rib. Then take an instrument called as a periosteum elevator and lift that periosteum to get access into the intercostal space. And once you've done that, then you open the intercostal space. In this particular case, I am actually harvesting the intercostal muscles because I'm probably wanting to put it on the bronchial stump after lobectomy. Okay, this is not a routine thing that you do. And then you put this finisciator. This retractor is called as a finisciator retractor. You put it one there, one here, and open it laterally, and then you get access to the lung. And you can see I'm right on the fissure. Can you see this? This is the fissure. So this gives you access to the fissure and allows you to do any thoracic surgery, whether you're operating on the lung, whether you're operating on the diaphragm, whether you're operating on the thoracic outlet, you can access everything through this incision. Okay?
Yeah.
Now closure. Closure is very important. I did tell you, you must put pericostal sutures, which is 2 sutures around the rib, and you bring it together to put the rib back. You don't close the intercostal muscle. You just put the 2 ribs around. Some people make incisions in the rib, make a hole in the rib, and then put the sutures through the 2 ribs and put a wire together to put the ribs back together. And then the next layer to close is thoracodorsal. So the reverse of your thoracotomy. So thoracodorsal fascia, the latissimus dorsi, the subcutaneous tissue, and the skin. Okay? Did it make sense, guys? Whoever is on the call, this is a very, very important operation. It needs to be described. If you are ever asked anything in thoracic surgery, this is the commonest question you'll be asked: a posterolateral thoracotomy. Okay. Now, this is the instrument set that you need when you're doing a thoracotomy. This is called as a retractor. This is a finisciator retractor. These are called as lung graspers. This is a rib approximator, which helps you to approximate the rib when you're closing. This is a lung retractor, so you can safely retract the lung. And this is a periosteum elevator. 1, 2, and 3, these are all periosteum elevators. And this is a rib cutter. Now, when you cut the intercostal muscle and cut the intercostal space, when you put in a finisciator retractor, the rib is very tight. Okay, the intercostal space is very tight. And so you have to open very gently. Okay, 1 turn at a time. Let the ribs get used to that retraction. And then after a few minutes, a second turn, a third turn, a fourth turn. Sometimes in people, you may not be able to retract adequately and not get adequate exposure. And you might end up fracturing the rib. If you fracture the rib while doing a thoracotomy, these are very painful things because the intercostal nerve is a sensory nerve. And because it's a sensory nerve, any rib fracture which happens, when it heals, it is severely painful. So sometimes if it's too stiff, then we will electively make a cut on the rib, on one of the ribs. And this thing is called as a rib cutter. This sits into that rib and you can electively make a cut so that when you expand or open up the retractor, you do not have to worry about making a rib fracture. You make a surgical rib fracture, which is in one straight line, and it heals much better than a traumatic rib fracture, which will be in a horizontal, awkward line. That's why you electively can cut a rib to get access into the chest. So this is a periosteum elevator. These are some specific things. I won't wait for this. This is for the FRCS cardiothoracic guys. But because we have a lot of general surgery and medical students, I won't waste time on this, okay? So these are all the various retractors that are available. This is a scapular retractor. This goes below the scapula and you lift it up to put your hand beneath it and count the ribs down, okay? This is a rib cutter, a standard rib cutter. This is a horizontal rib cutter. That was a vertical rib cutter. So there are various types. This is a lung retractor. It does not damage the lung when it retracts, okay? And this is a Duval lung force. You can actually grasp the lung with this and very safely move the lung right or left and not have a major problem, okay? Again, these are some vascular clamps. I don't want to talk much about it at this moment, okay? So this is for the, okay. So I spoke to you about chest wall muscles. I spoke to you about intercostal muscles. I spoke to you about chest wall anatomy. I also want to talk to you about how can you enter the chest without actually cutting any muscles? Is it possible? And the answer is yes, okay? You can cut, you can go into an area which is called as the auscultatory triangle. You can raise the skin flaps, but instead of cutting the latissimus, you actually go to the top edge of the latissimus. Let me just come out of this thing and show you the chest wall anatomy again. So when you are doing a muscle sparing thoracotomy, you actually make an incision here, but you don't cut any of the muscles. You actually dissect this latissimus dorsi and lift it up. And you dissect this trapezius and lift it up. When you lift the trapezius and the latissimus dorsi to the side, you can directly get access into the chest through an area which is called as the auscultatory triangle. And I'll show you what that is, okay? Just 1 second, sorry. So this is the auscultatory triangle. So when you do a muscle sparing thoracotomy, you actually make an incision on the skin and subcutaneous tissue, but you lift the latissimus up, you lift the trapezius away, you do not cut the serratus, and you get into this area. And the beauty of this area is you can directly enter into the chest without cutting any muscles. You will enter onto the intercostal space directly. And that is why clinically, when you're examining a patient, auscultatory triangle, it's called a triangle of auscultation because when you put your stethoscope onto this area, there is absolutely no muscle that comes between the stethoscope diaphragm and the lung. So when you put your stethoscope onto this area, you get the best quality sound of the chest sounds, okay? And this is the importance of the auscultatory triangle. And this is again asked frequently in the exam. Describe the boundaries of the auscultatory triangle. And so you've got the trapezius and you've got the latissimus dorsi, and this is the scapula. So between these, you get this, what is called as an auscultatory triangle. And then you do a muscle sparing thoracotomy. So you actually lift up the This is the latissimus dorsi. You're not cutting the latissimus dorsi. You're using diathermy to lift up the latissimus dorsi. See, it's being pulled away to one side, and then you can see the ribs here. Can you see the intercostal space and rib? So you don't have to cut any muscles. And above, you move the trapezius to one side, the serratus doesn't come in your way, and you directly reach the thoracodorsal fascia. This is called as the thoracodorsal fascia. And you can very easily cut, and then you have to put two retractors in this situation, because one retractor holds the latissimus dorsi and the serratus away, and the second retractor pulls the rib away. Okay, so this retractor is in the intercostal space, whereas this retractor is in the extra thoracic space where it is pulling the muscle away without cutting the muscle. Because if you don't do this, then the muscle keeps coming in your way and you don't get a good access to the abdomen, to the chest. Okay. Now, auscultatory thoracotomy, if you go only through this one, then you just make this incision, you're directly onto the intercostal space. There is no muscle here at all. And you just make an incision on the top of the rib, and you dissect the intercostal space, and this is the rib which is isolated with the periosteal elevator, and bang, you're into the chest. This is a good incision for small procedures like bulectomy, pleurectomies, and things like that. Okay, and it allows you. And then closure, I told you a pericostal stitch. This is a pericostal stitch. This goes around the rib, and you put a big stitch all around and tie it down so that you can get a good closure and approximation and prevent what is called as lung hernia. If you don't get good approximation, then with every breath, the lung will herniate through this, and it will give you a very unpleasant sensation for the patient. Okay, so that's quite important. Okay, did it make sense what I just described?
Yeah, it did indeed.
Hello? So posterolateral thoracotomy, we've described muscle sparing thoracotomy. We've said a thoracotomy through the auscultatory triangle. The other one important incision on the chest wall, which you need to know, is a median sternotomy. All cardiac surgeons and all thoracic surgeons know how to do a median sternotomy. The advantage of median sternotomy is it's quick to perform. There is no muscles that you have to cut. You get very good exposure to the heart and the major vessels. It is very safe. It has been used thousands and thousands and thousands of times over the last 20, 30 years, because all cardiac surgery is done by cutting the sternum. And the other thing is it heals beautifully. If you get the sternum approximated very well, and you approximate it well with the sternal wires, you do not get pain. The pain with median sternotomy is actually very less as compared to a pain with a thoracotomy. Because when a thoracotomy heals, the scar tissue still involves the intercostal nerve laterally, and the intercostal nerve is a sensory nerve. And unfortunately, in about 2% of patients, you get what is called as a post-thoracotomy syndrome, which means chronic pain, which causes great discomfort to the patient. As opposed to that, a median sternotomy, even though you're cutting through the bone, that is not as well innervated. And when the bone heals, the pain with the median sternotomy is much less. And this is again a question that comes in the MCQ and you're asked in the exam, okay? The disadvantage is obviously a cosmetic issue because it's a midline thing, you know, it's visible. You cannot wear a low neckline. And the problem with median sternotomy is it gives great exposure to the heart and the great vessels, but it is a problem when you have to operate on the lung and the posterior mediastinum, because to the side, you cannot get as good an exposure with median sternotomy. And sometimes when the sternum becomes infected, then you really get a big problem with deep sternal wound infections. And that can be a nightmare for the patient, which can sometimes take months and months to heal. And that's an issue for the patient. Whenever you cut the sternum, after you've cut the skin and the fat, you come to the bone, the sternum itself. You cut the xiphisternum with a scissor because that's a cartilage. And then you use this thing called as a sternal saw. This is a vertical sternal saw. You just hook it underneath the sternum, and then you cut all the way in a straight line to the top. This is a horizontal saw. This is a vertical saw. This is the saw here, and this is a horizontal saw. This saw is usually used, a circular saw is used when you're doing a redo sternotomy. You know, when you operate on young children with cardiac surgery, or people have aortic valve replacements and things, it is possible that they may need a redo surgery in the future. The problem with redo sternotomy is that the lung is always stuck, the heart is always stuck to the back of the sternum. And so you cannot put a vertical saw and cut across, because you will cut through the heart. So you have to use a circular saw, which gradually goes through the various tables of the sternum, and you can carefully open the sternotomy a second time, a third time, a fourth time. Okay. This is a retractor which opens the sternum to one side, and then this is called as a IMA retractor, which means it lifts one side of the sternum up, depresses the other side, and you can harvest the internal mammary artery, because it allows you to look at the underneath surface of the sternum. Okay, these are some snuggers that are available. So this is how you do a median sternotomy. The head end is here, the feet are here, the patient is on his back. You are standing on the right side of the patient. The assistant is on the left side. You feel for the jugular notch, which is the notch just above your sternal bone. Feel it, all of you. You feel for the sternal notch. You feel for the xiphisternum, which is at the bottom here, and you make a vertical line between the sternal notch and the xiphisternum, and you cut along the vertical line. Then you get skin, you get fat, and then you're directly onto the sternum. Can you see that? Skin, fat, but no muscles, hardly any muscles. There will be very little here. You just get directly onto the periosteum. This is the xiphisternum, which you've cut with a scissor. The top end is the sternal notch, and you feel the two sides to make sure that you're in the midline. So you feel the intercostal space on both sides and make a line with the diathermy to give you a sense of where is the midline of the sternum. And then once you know which is the midline of the sternum, then you put this vertical saw at the xiphisternum. Some people come from top to bottom, but most people come from bottom to top. You hook it around the sternum, and then you just cut it vertically across, and then put a retractor, and you will directly see the pericardium, the great vessels. And if you've opened the pleura, then you will see the lung coming into the picture as well. The pleura is usually opened when you are harvesting the internal mammary artery. Okay. And this is some surgery which we have done, taking out a large anterior sternal mass. So this is thymic mass, which we are taking out, and that's coming out through a median sternotomy. Now, the beauty of median sternotomy is you can close it really well. You put steel wires. These are steel wires, 6 to 8 steel wires. You go across from this side to this side, and then you approximate it in the midline, okay? So that you get a proper approximation of the bone. You must make sure that two edges of the bone approximate. It's like putting a splint on a fracture. So you have to make sure that you're splinting the fracture really well and closing the midline really well, okay? Otherwise, you get movement of the sternal, two ends of the sternum, and that usually gives rise to infection. So a good approximation is very, very, very important. There are various other techniques how sternums can be closed. The commonest, very important one is a Robichek's method, where you go vertically inside out, inside out, inside out, to give stability to the lateral margin, particularly in a old patient with osteoporotic bones. If you put the sternal wires through the bones, they may cut through, or the bones may fracture. So you put a vertical line on the two sides, going inside out, and then put your wires around those vertical lines. So the pressure of the wire is on the vertical wire rather than on the bone. And this is specialized techniques that you need to know. There are newer things available to close the sternum. This is a band. This is like that zip tie that you get. So you put the tie across from here and then zip it into this, and you just close it exactly how you would close a bag or a rubbish bag with a zip tie. So this is available in the market. You've also got some specialized plates and things which are available in the market, which allow you to get good closure of the sternum. Okay?
Yeah.
Okay, these are all specialized things. Okay. Are you okay with this so far?
Yeah, we are, sir.
Okay, I've got about 7 more minutes because I have to go at 3:15. So I will try and talk you through a clamshell thoracotomy. This is very important in trauma, okay? And very important when you're doing bilateral lung transplantations or when you're doing a heart and lung transplantations, okay? And a clamshell, or when you're doing a large anterior mediastinal tumor, which is going into both the pleura, that this incision gives you access to both sides of the pleura and to the mediastinum. And it is like this. You have to actually come across like this, cut across the sternum and go across like this. And that is what is called as a clamshell. So you cut, and the muscle that you cut here is the pectoralis major, okay? Skin, subcutaneous tissue, pectoralis major. And then you come to the intercostal space, you cut along on the periosteum of the intercostal space, both sides, and then you can cut the sternum either with a sternal cutter, you can use a giggly saw to cut the sternum across. But the problem here is both the internal mammary arteries go vertically like this. So when you make a clamshell, you invariably compromise the internal mammary artery, and you've actually got to tie and ligate it so that it doesn't bleed. Okay, so this is a clamshell. See, you've opened the right side, you opened the left side, and you've cut across the sternum and completely opened. So you can see the heart, you can see all of these major, this is the aorta, this is the SVC, all the major structures are seen. You can see the right lung, you can see the left lung, and this is an excellent incision in trauma, particularly when you're dealing with cardiac stabs or you're dealing with bleeding from aorta or bleeding from the pulmonary artery. The clamshell is a very quick access into the chest. And if you know how to do this, you might actually save a patient's life. In fact, we are going to run a course next month or the following month, teaching students how to do anterior thoracotomy and how to do clamshell thoracotomy on cadavers. And I invite all of you who are there to try and register yourself with this course. This is accredited course for trauma, and you will be accredited for knowing how to do a clamshell thoracotomy. And this is the closure of the clamshell thoracotomy. Can you see? So it's a very nasty looking incision, but it gives you the best access to both sides of the chest. And it is life-saving, particularly when you're doing in trauma settings. Okay. Yeah. I think I'll stop here because I unfortunately have an appointment at 3:30 and I have to go. My next segment was the surgical anatomy of the lung and the surgical anatomy of the bronchopulmonary segments. And I was going to take you through how you would do a lobectomy in the settings of a lung cancer. But I think I think I'm 3:11, so I just have to stop here. Yeah. Okay. All right. Thank you very much, guys.
Thank you so much, sir. Thank you. Thanks.
So, I mean, does this time suit you guys or does this time not suit you guys? I don't know. So give me some quick feedback. I have 3 or 4 minutes.
So this is the best time. This is good time, sir.
It's a good time. What country are you from? Just tell me. I can't hear.
So from Delhi, sir. Delhi, New Delhi.
Okay, India. You're from Delhi. So India is good. What about the UK guys? Is this a good time for them or is it a difficult time? UK?
Hi, Mr. Khan, with you, Mandisha. I think
Mandisha.
it was fine for me because I'm off duty, but you know, like in usual working days, I think
it'll be difficult. Okay,
yeah.
That's good. That's good. Mandisha, did it make sense to you, the incisions?
Oh, of course, Mr. Khan. It was very.
The images are all.
All excellent. Thank you, sir.
Okay, good. I want a feedback from the medical students. Did you understand what I said? Is this the way you want to learn anatomy, or do you want me to do just anatomy and then not talk about surgery? I want a feedback from medical students. Hello?
Can someone from the students please respond to this?
Just speak. Don't worry. You don't have to worry. Just talk to me. I'm very, very approachable. You can criticize me. That's okay. Hello? Nobody?
Hello, sir.
Shubham.
Dr. Shubham here.
Hi, Shubham. Tell me.
Yeah, sir. I got it, sir. Much more concepts clear now, and it's very good, sir. Thank you, sir.
So this is the way you want to learn anatomy, is that correct?
Yes, sir. Yes, sir. Sure, sir.
Okay.
Absolutely.
All right. Shua, you are general surgery, so you tell me, did this make sense or was it too advanced for you?
No, sir. It did make sense for me, and also I'm gonna sit for MRCS soon. So these are most of the questions that we come across in MRCS.
Yeah, these are all questions which will come in MRCS. That's fine.
Yeah.
The slides have been prepared in a way that they answer some of the MCQs. And also on the Viva table, you'll be asked about thoracotomies and anterolateral thoracotomy. So next time we can do the lung, the anatomy of the lung and the bronchopulmonary segment. And then we can talk about how we do a lobectomy. And then following that, we can also do anatomy of the mediastinum and talk about how to do a thymectomy. I think anatomy should be learned with a surgical background rather than just showing pictures. And if anybody's got anything to type on the messages, you can do that. Shua can read those questions to me. Okay, thank you very much, guys. It was a pleasure to teach you guys, and hopefully mainly my aim is to teach the FRCS and the FRCS general surgery and the FRCS cardiothoracic. Somebody's hand is up. I don't know whose hand.
Yeah, it's
whose hand is up.
Do you want to ask something?
Hello, sir. Abdurrahman Muhammad, cardiothoracic registrar from Ireland.
Hi, how are you?
Yeah, thank you for this nice sessions. Would you mind to arrange one for an instrument, please?
Yeah, I do that. I do a dedicated session on thoracic instruments for the FRCS cardiothoracic surgeons. Okay. See, your best person who will organize all this is either Shua for general surgery and Kadri for cardiothoracic. Kadri is just going for his exams. So whatever topic you want me to cover, just get in touch with Syed Kadri and he will make sure that I will prepare the topic for you.
Great, thank you so much.
Yeah, no problems. Okay. There's a message from somebody. Somebody's got a message.
Yeah.
Use of a vertical thoracotomy. Yeah, that's a very good question. Axillary thoracotomy is usually used when you want to approach the first rib. Okay. The first rib is possible to be approached from supraclavicular. It can be approached infraclavicular, or even better, it can be approached through an axillary thoracotomy. And that allows you to get to the thoracic outlet. And resection of the first rib works very well. For some people, very few people in the world, they use axillary thoracotomy as in they make a vertical incision on the skin and the fat, but they make a horizontal incision on the sixth intercostal space. So they can do a lobectomy that way. But most of us do a axillary thoracotomy for first rib excision or resection of the band, thoracic band. Okay. Yeah. Shua said all these lectures I have done 100 of them, about 108 I think, or 110, and they are all in much more detail on thoracic gurus, and they are freely available. Okay, so please go on to thoracic gurus, and each lecture is about 2.5 hours, so it would be worth going through the whole lecture, and everything is covered in detail, all of thoracic surgery. And in fact, a lot of the link here. So thoracic gurus, just type in. Best is to subscribe to the channel and you can get all the lectures, and most of the teaching is like what I'm doing now. So it is an interactive session. Okay. Yeah. What is BRETAC Medics YouTube channel? Is there a channel like that? We can put it up there. I don't mind.
Yes, sir. So BRETAC Medics is the platform which I have formed along with my friends.
Fantastic.
And this is where we are doing this from.
Yeah, you can put this onto the BRETAC Medics YouTube channel as well. I don't mind at all.
Thank you so much, sir. So just one last question. You mentioned about registering for the course you're going to do for thoracotomy. How can we do that?
Email me, alizamir.khan. My name, alizamir.khan at nhs.net. It's 3:17. I have to go because I have a 3:30. Bye, guys. See you. Okay.
Bye. Thank you so much, sir. Thanks. Bye. Bye. Thank you. Thanks so much, everyone, for attending. I'll be dropping the link to Thoracic Guru session and then how to register for the course. I'll speak to Sir and then I'll get the link to register for thoracotomy course and then I'll drop it in the chat box. And also this recording would be available in the chat box as well. I think that would be in the next couple of hours. Thank you very much. And if anyone is interested in attending further sessions by Retractor Medics, you can drop your email in the chat box and then I will be sending you emails for our further sessions. So I think that's everything for today.